I believe that it's absolutely essential to have these discussions prior to the point when death is imminent. The first scenario that I will pose is one, and I'll use this phrase as I heard growing up from television, as the officer would give his narrative, the names have been changed to protect the innocent. There is a young lady who is on a ship in the Navy. Her father is very sick. She has come home and signed DPOA paperwork, dual power of attorney. Then she is deployed for war. Her father continually gets more and more sick to the point of real decline. There's a referral from the doctor to hospice, placed on hospice care. As the father has been diagnosed with a dual diagnosis of cancer that has metastasized to the bones, and not only that, but senile degeneration of the brain. The father has gotten to the point where he's verbally non-responsive. Now the father's not eating. Subsequently, the daughter is called. As she is called and asked to hurry up and get there because they feel like now death is imminent. Upon arrival, the daughter says, well, I'm not ready for him to be gone yet. There was no advance directive, nothing in place. And so she suggests the feeding tube. There's the pros and cons about the feeding tube. She says, go with the feeding tube. Patient gets a little bit better in a couple of days and is now eating. Patient now begins to aspirate and takes last breath. No DNR is in place. Subsequently, CPR is performed. Because of the metastasizing to the bone, several ribs are broken during the CPR process. Soon after, the patient is revived, resuscitated, and now living again, chokes again, and dies a very horrible death. Not only that, but she finds out that the patient now she doesn't know if the patient has any insurance because there's been no conversation. So she solicits for money from a branch of military service. They give her a little bit in order for a cremation. I come in because her faith tradition tells her that not only will her father burn once, but will burn twice. Subsequently, after the cremation, she finds out that the father, being a worker for the federal government, had a FedLeg insurance policy and could have had a traditional burial. The woman is in deep depression because of this and is placed on antidepressant meds and is still seeing a counselor on the ship. Another scenario, one that is very different. There is a patient, a female patient, who has done her advanced planning. She is told about what she considers to be quality of life. And with that being said, the patient experiences her rapid decline, stops eating, and she has been diagnosed with senile degeneration of the brain as well, in addition to having some heart issues. So she has a pacemaker with a defibrillator. At the time, once they have looked over the paperwork, the children and grandchildren have looked over the paperwork, as this patient is about 90 or so years old, they say, well, we believe that it's the time. The whole family comes in. This patient is also in hospice care with myself and the pastor of the family. and they're around the bedside while the nurse utilizes the magnet to deactivate the pacemaker. About 3 hours later, the patient passes with the family, reminiscing and singing her favorite hymn as she takes her last breath. That's important when it comes to advanced planning.
Sure. So there are, it seems to me, examples of tamed. I don't know if you heard my little spiel starting the conference, but the distinctions between tame dying, wild dying. And I guess one point here is the disastrous consequences of not having information, conversation about values, preferences for care as exemplified by your first case. So hold those thoughts right now. We're just going to go to the next panelist, Joanne, to give us her thoughts about her experience, these experiences.
Good morning, everybody. My name is Joanne Sauter.
We may need you to hold the mic a little closer to you. So.
Good morning, everybody. My name is Joanne Sauter, and I'm a Burmese interpreter. I want to share a couple of things. The first thing was...
Can you hear Joanne? No, you have to... You have such a beautiful, soft voice.
I would like to share a couple of things here. One is my own family. When I was living back in Burma, we have 3 generations live in our home, and my grand uncle, who was he has his lung, he has an infection in his lung, and he has some heart failure, and so we was wondering what we should do for him, and we went to the doctor, and the doctor said it will be not too long for him, what you want to do. And so we asked, the family was having meeting and talking, and then my grand uncle said he'd rather stay at home, be with the family, and praying and comforting him. That's all he wanted. And so my mother and my father said, okay, so we have that with all the relatives and being, carrying him, and with the doctor will come and visit. And so it was a family and the relatives and the community and came and be with us together till he passed away. It was a very comforting for my grand uncle that he, able to be at home with the family. That was a very good experience for us. And I came here and I've been working as an interpreter with the community. And I have a couple of things that I saw. One was a child who was very ill. As refugees, the parents, they have no knowledge about what's going on here and how to be able to present or what they can do. And the baby was very ill, and it was in the hospital. It was all hooked up with the machine, everything, and the mother was terrified. She didn't know what to do, and they said that we had to wait and see. We can't do anything yet, but, with the feeding tube and with the machine. And the mother was just there looking at the child, and without knowing the language, mother suffered a lot of it. And so I was there as an interpreter, interpreting, and able to, beside my interpreting, comfort the mother in the sense. And they was waiting for the dad. The dad was working in St. Joe, and then they had to wait for the dad to come back. And they said, this is not, we can't keep this too long because the baby is suffering a lot. And so when the dad came after, when dad hold the baby, they pull out the plug. And this very sad situation, not, like in the back home in Burma, right. That, in the community that was in the hospital, just the mother and the father and I was there, and all the doctors were there helping them, but it was totally different. And the mother suffered for a long time with that baby, went through with that, and without having comforting. So it was
Right.
a learning experience for me in knowing what they went through, and it's very sad to see that.
Sure. So the power of being able to live within your cultural background and negative effects of being translocated from that culture, I think, are very important messages there. And our cultural traditions, as I'm hearing this, really are some of the important things to remember and reclaim as we balance the moral and the technical order. So thank you for that. We'll come back. So Janet, Joanne's daughter, right? Tell us.
I have something that I've put together, so I'm just going to go ahead and read it.
Mm-hmm.
When John asked me to speak this morning about the final months of Mom Joanne's life, I decided it had to come from the heart, from my heart. I wanted it to be personal. I knew I wanted to weave it into the passion she felt about the Center for Practical Bioethics. As everyone knows, practical bioethics is about dying with dignity. She loved the center and its work. Mom was determined to die the way she lived, with courage, strength, and dignity. She passed the importance of all those qualities to her husband, family, and friends. Even though Mom was dying, she wanted to do the things she liked to do until she couldn't. She loved to shop. So we would go shopping. She always made sure she had lipstick on, a splash of color, and a scarf to finish off the outfit. She always looked beautiful. Through the years of her sickness, there were lots and lots of tears. There were quiet, intimate conversations with her husband Bert, myself, my sister Jane, my brother Bill, our spouses, grandchildren, and others. She always seemed to be surrounded by family and friends. We had wonderful dinners out on the patio or in the dining room, talking lively, debating, laughing, and listening to stories. As time went on, Mom started feeling worse. She told me she wanted to see her longtime, close women friends. I'm not quite sure how I came up with this idea, but I decided to give Mom a meditation party. We invited her close friends to come and send good thoughts her way. The day of the party, before everyone arrived, I could tell Mom wasn't feeling very well. Before Kathy, our Pilates yoga teacher, started the meditation, I said a few words, and then I asked Mom if she would like to say something. She started by welcoming everyone and told them how happy she was that they were there. She apologized for not being able to send thank you notes to the notes that she had received, which speaks of her generation. But her hands weren't working very well. And then I thought Kathy would start the meditation. But Mom didn't stop. She went on to say to all of us there, from the very beginning of when I was diagnosed with cancer, I had to make a decision on how I wanted to die. I received numerous suggestions on what I should do and who I should see. I decided that I was going to go on a journey, and that is what I call it. It involves all of you, of course, Bert, my children, and grandchildren. This journey is open to anyone who wants to be a part of it. When I found out I had terminal cancer, I knew I didn't want to go through chemo. I went through radiation and medication. This is my choice. As all of you know, the journey has continued. It has consisted of opening doors, talking freely at any time, at all times, to talk about what is important to all of us, meaning my children, their spouses, grandchildren, and with Bert. I hope if any of you ever have a problem, medical or otherwise, you will open up to your family. The rewards you personally get are one of my most important messages. I just want to end by saying, through this journey with cancer, I am free. I am totally free and at peace, and it is the greatest feeling to have. There is no other way to describe it. When Mom passed away, she was totally at peace, surrounded by her family. The hospice nurse who was at our home said she had never seen anyone die so peacefully. She was able to do that because she learned so much from the Center for Practical Bioethics. She left a legacy that I hope someday I can fill and pass on to others. Thank you.
Yeah, thank you, Janet. It sounds like the fact that your mom really had the opportunity to express her choice really contributed a lot to humanizing her whole process and making her and enabling her to be at peace, which is so important. So, we want to come back to that notion, but thank you for sharing that. And our last panelist is Daniel Serda, who will share some of his experience.
Thank you. I appreciate the opportunity to be here. I want to be very direct because I think these issues are, as you'll see, very challenging. There are three words that I would use to characterize the last 5 months or so of thought that I've had since my mother passed. And the first one, the obvious one, is grief. The second one is frustration. And that has more to do with her experience toward the end of her life, and I'll explain what I mean by that in just a moment. And the third one, I asked someone last night, is this too strong a word? And they said, no, not in the context of what you're talking about. It's an important word for people to understand. And it's the word terror. And not for the obvious thing. It's not terror of death itself, but terror of some of the challenges that my mother's experience revealed to me. My mother was a caregiver her entire life. She grew up with 7 siblings. They were all younger than her. My impression, based on the stories she told me over the years, is that she very much was involved in caring for them. She grew up in rural Mexico, and her parents, from a very young age, were agricultural laborers. So they were working a lot. She began working as an agricultural laborer when she was about 11 years old. And there was a brood of kids to take care of. She met my father when she was around 20 years old, and he had been recently widowed with 6 children. And when they were married, there was more than a 20-year age difference between the two of them. And in the bargain, she agreed to care for his 6 children and a daughter she already had. She raised all of us. And as the tendency is, many of those children started having children eventually. And she raised many of those grandchildren as well. She cared for my father during the last 3 years of his life. He suffered a major stroke because he had uncontrolled diabetes and uncontrolled high blood pressure. My father was very leery, and he would have a different definition for you, the word terror, of going to the doctor and being told essentially that he was going to die. So he avoided going to the doctor. And the really unfortunate consequence of that is he lived his last 3 years of his life permanently disabled and with very severe cognitive deficits. After my father passed, my mother really went into a profound depression. Now, she was in her early 60s at the time. This is 20 years ago. But what brought her back was an opportunity to work for a social service agency in Kansas City, Kansas, El Centro. She worked as a receptionist. And in that role, she took on an entirely different phase of her life where she wasn't giving care, but she was providing empathy to people who were coming to El Centro seeking assistance. I had the privilege just a few days ago of visiting with one of her best friends, Sister Alicia Macias, who was a founding board member and employee of El Centro for many years, who's now at the Cordy Marian Retreat in San Antonio. And one of the things Sister Alicia and I were reminiscing about was just that it was so interesting that my mother went from all of these phases of providing care to providing really love and empathy and respect and dignity to a lot of people. My mother's significant health problems, which I could talk about all afternoon, really started about 8 years ago. And by the time she passed, she had 13 diagnosed medical conditions. Her most significant was congestive heart failure, which most of you probably know is a chronic, manageable condition. And she had a couple of other significant conditions. She had peripheral artery disease, which was largely a consequence of bearing 10 children. And as a result of that, about a year and a half ago, she lost one of her legs. So in the last year or so of her life, she had very significant disability. But despite that, my mother was a fiercely determined woman. She was ambulatory. The doctors were always amazed to hear that. What, she can do assisted transfers? Yes, she can. She not only can do assisted transfers, she did 9 weeks of physical therapy and rehabilitation this summer because she was trying to get herself prepared for using a prosthetic. There's nothing easy about death, and the grief part of it really comes down to this. My mother had a little blip. Her congestive heart failure went uncontrolled for reasons I won't get into. She went into the hospital for a day or so. They adjusted her medications orally. She was discharged. I took her to a clinical appointment the following week, and we were talking about some possibilities that this particular doctor, who was a rheumatologist, thought might account for some of her issues. And I asked him, I said, well, if we get a more definitive diagnosis, will that help us with care and treatment? And he said, well, I assume you understand it's not going to change the end point. Your mother's becoming frail. She's 82 years old. She's got a lot of health issues. I said, of course, I understand that. Everyone has to come to terms with that. I said, but really, to me, it comes down to something very simple, which is her quality of life and her certainty and peace of mind and these things. And he said, well, I hope so. Well, unfortunately, before we get to that point, she was back in the hospital because during that 48-hour or so stay, she acquired pneumonia. She had healthcare-acquired pneumonia. That was treated, resolved in less than a week. There was some uncertainty among the medical staff about whether it was appropriate medically to discharge her to go home or whether she should go to skilled nursing. And I remember having a conversation with the social worker and telling them, wherever the setting is, it's just a matter of, my mother making that decision. He was very surprised to hear she could do that because she was very frail, but my mother, unlike my father, never had any cognitive decline. And unfortunately, it took too long to make that decision because in the meantime, she acquired a staph infection, in fact, MRSA, a blood-borne staph infection that ultimately took her life. That's not the frustration piece. The frustration piece really has to do with the complicated family dynamics and the challenges of navigating the healthcare system at end of life. My mother, because of all of her conditions, was seen by a lot of different specialists. She was seen by a lot of different hospitalists in the hospital environment. And it's a cliche, but it is absolutely point on. It is like the parable of the blind men and the elephant. Every practitioner she saw was looking at a little tiny piece of a larger puzzle. And that brings me to the last point about terror. As I said, it's not terror of death. It's really terror of the challenges that exist in the structures and the care that we've established for ourselves. there were so many difficulties navigating everything from Medicare and Medicaid to reimbursables to costs, particularly the cost of providing in-home care for my mother because she was not technically Medicaid eligible at the time she had her surgery. But my general sense, having reflected on this for some time, is, and I said it's that sense of terror. It's not terror of death, but to me it's terror of the challenge that we have yet to conquer for ourselves. Because to go back to what Dr. Payne said at the beginning, this idea of demedicalizing and focusing on dignity and end-of-life care, it's very difficult to do that when day in, day out, my mother as a patient is dealing with all of these little things that are giving her different symptoms, right, that are making her uncomfortable. And we as family members were having to contend with a lot of different practitioners, right, who couldn't really come to resolution on what the appropriate medical course of care was going to be, let alone the actual process. Now, that being said, her final days were spent at St. Luke's Hospice, which was without a doubt the best part of her journey. By that point, she had come very much to peace with herself and was provided wonderful care, excellent care at the end of her life. She passed away in the middle of the night. I was holding her hand when she died. Yeah. And I don't know what more I could ask for than that. Yeah. But this is, as you can tell, I mean, this is very recent, and I'm still in the midst of sorting all of that out.
Sure. Thank you, Daniel. Can I ask you, when you say her final days were in St. Luke's Hospice, how final were her final days? How long was she in the hospice?
She went in Wednesday afternoon and passed away at about 6 a.m. Sunday morning.
Okay. Dr. Legret, Dr. Twaddle, I can't remember the statistic in my head, but what percentage of people who are in hospice are in hospice less than 1 week? Isn't it 30%? So right. And so when did, that was actually a question I wanted to ask you. When did hospice actually come up in the course of your mom's?
She had one
care.
After her surgery, she had one brief course of hospice, which had to be discontinued because she was recovering. She joked about this because she had a friend. She said, you know, I had a friend when I worked at El Centro. They kicked him out because he wouldn't die. And she said, and that's what they're going to do with me because I don't plan to go anywhere. Right. It was very late in the process, to be honest with you, later than it should have been. And it was actually, it was not the first suggestion that the medical staff put in front of us. They were really suggesting that she die in the hospital. When I talked to my mother, she said, if this is this, I'm going home. And the issue was she could not go home with the degree of care that she required.
Right. So, Daniel, let me ask you this. So knowing what you know now, if you had a family member in a similar circumstance, do you think that you and your other members of your family could hear earlier referral to hospice is something you could hear? And I guess the implication here is that did you find the hospice experience, albeit the last few days of your mom's life, kind of the most humanizing experience in her care?
Well, I'll answer the second question first because that's a really easy answer. And it's absolutely, it was much more humanizing. The first part is harder because one of the reasons I mentioned my father is because it would have been a much simpler decision for my father. Mm. As I said, I mean, he lived with really severe cognitive deficits. My mother never had any. She was always of sound mind. She had a lot of what I would call physical struggles, and she always described it as, you know, my body is just giving out on me. Right. And even her last experience there, I mean, she contracted pneumonia, but she was over in about 5 days with standard IV treatment antibiotics. It was the blip of the MRSA, which changed it. And I guess the only part of the conversation it may have changed would have been that last course of the last couple of weeks and the degree. Because, and again, it's just not an easy answer for me because I have to tell you, my mother was very insistent. We sat down with her multiple times with the practitioners, and they talked about side effects of the antibiotics they were going to have to put her on. They talked about the challenges. They talked about the likely outcome. And she was insistent all the way to her third course of antibiotics that she wanted to try to beat the MRSA. Mm. And that it just
Yeah.
made it too difficult.
So-
And again, if cognitively she had been in a different place, it would have been an easier decision to make, to be honest.
Okay, now let me ask, before we throw this open to the rest of to the audience here, the other three panelists, Janet, Joanne, or Reverend Sprite. So just thinking back on your stories, what kernel of advice or wisdom would you give to us? One or two just thoughts about what in the experience of your loved one or the patients should have been done either differently or you wish there had been more of to humanize the experience of end-of-life care?
That's difficult to answer because Joanne had everything planned. She knew the way she wanted to die. I think one of the things that if I had listened to her a little more carefully, and my sister and brother can agree with this, I wouldn't have asked her to drink so much Ensure. Because she finally looked at us and said, I don't want to eat anymore. I'm done. And I do not think that we could handle that as much as Mom could.
Yeah.
She knew that it was time, and she was at peace with that, like I said. And I think it was more all of us that were not ready for her to go.
Okay.
And I think that's a difficult position to be
Sure.
in sometimes.
Sure.
But we did it. We did finally realize that Mom had control, and which she always did.
Yeah.
And it was a very peaceful, very good death,
Yeah.
as a death can be.
Yeah. So, Joanne, so with the patient and the family who had the sick child, and you were translating, looking back, what could the medical team, the hospitals, institute, what could they have done better to make that more of a humane, human experience for them?
As an interpreter, it might be better that they will have a little bit more helping to understand. Not that they are not helping, but it is a lot, because these families who came as refugees, they came from way up on the mountains, and
Right.
we don't have any knowledge or seeing all in the hospital,
Yeah.
they think. So it is very frightening for the family.
Right. So more information, but what kind of information? More information about...
In the sense as explaining, okay, this child is, it's not going to get better. It's going to be passing away. Would you,
Right.
like to take the child home?
Right.
Or how do you like to have it,
Right.
in a way, in your culture,
Right.
or in some way, in a gentle way, you know?
Right. Okay, thank you. And Reverend Sprite, I mean, it's kind of obvious in that first case you talked about with the Navy veteran that I was obvious a lack of just dealing with or getting information from her. But so if you had that person in front of you now, what would you say to her? And what are your thoughts about what we could do to humanize and make more humane the experiences of illness?
Well, firstly, I would say that unfortunately, as a hospice chaplain, there are just too many people that do not receive the full benefit of this humanization that we speak of. And it's probably because of the lack of education when it comes to having an understanding of hospice. People believe that death is, immediately imminent when a person is placed on hospice, and that is not always the case. Sometimes a person has been restarted 6, 7 times. I've had patients that have been on for 2 years, and and they're still steadily declining. So my admonition to that person would have been, first of all, to make sure that the father received the benefit of hospice earlier on,
Right.
and at the same time educate them to the dangers of not having a DNR in place. For a person 80, 90 years old that has cancer that has metastasized to the bones, and to have to, experience something like that, it's really horrible. And I believe that if they know early on the amount of suffering that may be endured.
Yeah. But there are a lot of myths running around, right? So, well, that hospice, I heard they put Daniel's mom in that hospice, and 2 days later she was dead. So that hospice kills you. So,
right.
I mean, of course, it's a self-fulfilling prophecy, right? Because if you delay admission so long, people are literally on death's door when they enter. So there is this myth busting that, and I think do you think that the education has to be more than about just information providing, but some way gets to obviously the emotional resistance to and to give people some resources and ways to let go and to think about how they let go?
Well, as a chaplain, I'm partial to the spiritual component. So I would have to say that utilizing a person's faith tradition in the educational process, I believe, would be very helpful as far as making death a more humanizing experience.
Yeah.